Tavpritesh Sethi is a physician, scientist, and associate professor of computational biology at Indraprasth Institute of Information Technology, Delhi, and a fellow of the Wellcome Trust DBT India Alliance at All India Institute of Medical Sciences, New Delhi. Over the past 2 years, he has been a visiting faculty member at Stanford University School of Medicine from February 2017 to January 2019. He received his MBBS from Government Medical College Amritsar and PhD from CSIR Institute of Genomics and Integrative Biology. Dr. Sethi specialized in improving outcomes in neonatal, child and maternal health by bridging medicines and artificial intelligence. His research is focused on development and deployment of machine learning based solutions to enable decisions and policy in pressing healthcare questions such as antimicrobial resistance, sepsis, and health inequalities in intensive care and public health settings.
Yeah, so meanwhile, thanks again for having me here. I will give a background on some of our research and how it connects with the theme that is water for public health, and how AI/ML for healthcare actually also ties in with the current theme. So I will be talking about preparing for disaster and pandemic, especially the way it started in our lab, and it all started from water, sanitation, hygiene, when we actually were working in the space of tackling the COVID-19 pandemic. So I will start right away. But before going into our work, I will just spend a couple of minutes here on this news story that came out in January of 2020, as you can see the date here, 25th of January 2020, which the news story published in Wired says an AI epidemiologist sent the first warnings of the Wuhan virus. And you can see that at that point of time, we did not yet have a name for the coronavirus and the COVID-19 pandemic. It was early 2020, it had just started spreading. And this company called Blue Dot, based in Canada, had started sending warnings actually 10 days before the CDC alerted, and 7 days before the CDC alerted, and 10 days before the WHO alerted that a pandemic is imminent. And the way they were doing this was by sifting through lots of data that are unconventional data sets for epidemiology, such as flight data, ticketing data, what people were talking about on social media about diseases, right? So that those are unconventional sources of data which were used to triangulate the information on a spread of a pandemic across the globe. And the founder of the company, Dr. Kamran Khan, is actually an epidemiologist and a doctor by training, and moved to do data science research, and has been publishing in the space of the spread of infectious diseases by triangulating information. Early on, not just in the COVID pandemic, but for example, the spread of Zika from Brazil. And these papers have been published in top venues such as the Lancet, which means that there's a lot of scientific backing to how epidemiology and public health research going forward is being revolutionized by the use of unconventional data and AI. So I know this is not directly water and not directly water for public. I will go on to talk about our own research. You will perhaps make the connect between unconventional data sources, water, and pandemic preparedness. But the message that I wanted to give here was that if we use data intelligently, if we are able to triangulate information from conventional and unconventional sources, and then perhaps also look at the role of public health factors such as water, sanitation, hygiene, and make it work together with the conventional sources. For example, the administrative reporting of cases in the pandemic scenario, we should be able to put together systems that can help us to be better prepared for the oncoming challenges such as the COVID-19 pandemic. So to give a personal context to why our lab has been working in this space, so my background is in medicine. I did my MBBS in 2004, and then I moved to do a PhD in computational biology at CSIR IGIB. And in that during this time of doing my PhD, I was focusing on building models for for clinical scenarios such as asthma, respiratory disorders, and cardiovascular disorders. So for the last 15 years or so, we have been working in the space of building models using machine learning for clinical and more recently public health scenarios. I've been engaging with the All India Institute of Medical Sciences, New Delhi, in the Department of Pediatrics, especially in the ICU settings to build models that can predict critical outcomes in children and babies who are admitted to the ICUs. And you will see going forward why that connects with water sanitation hygiene, because we observed that a lot of readmissions to the ICU settings actually happen because of poor hygiene conditions at home. So children who get readmitted to the ICUs with sepsis or have poor outcomes, we know that there is a factor um, underlying that, which is water sanitation hygiene at home settings. And some of our research actually uh, uh, focused on addressing that part as well. So I've been a visiting faculty at Stanford University School of Medicine, where we were working on building AI/ML technologies that can be applied to the settings all across the globe, including the Indian settings and for public health. And I'll talk somewhat about that work as well. I've been an associate professor at IIIT Delhi, and also have been have had the opportunity to lead the Center of Excellence in Healthcare at IIIT Delhi, where we are building key cutting-edge technologies to bring more AI and IoT solutions for healthcare and public health on ground. So this is where I currently work. So many of you may know IIIT Delhi, but for those who don't, we are an engineering institution, a relatively young institution, about 12 years old, but with a very strong focus on shaping the society around us. So being an engineering institution and an IT institution, our core focus areas are computer science, but our departments are specialized towards different areas such as computational biology, applied mathematics, artificial intelligence, social sciences and humanities. So we have programs basically which at undergraduate, graduate, and postgraduate levels, which deliver education, conduct cutting edge research at these areas. So this is pre-COVID times, and and the book is Health Systems for a New India, published by the Niti Aayog. And I just like to use a paragraph from this book, which says, by introducing critical health systems transformations, India can save more than 1 million additional children lives and reducing working age adult deaths by an additional 16% by 2030. So I used this slide before COVID times, but now I think every one of us realizes that the challenges of having a new health system in place and the opportunity of having a new health system in place is really imminent, and we should be moving towards that. And many of you may know that these critical health system transformations involve having very basic uh, transformational steps such as availability of um, clean water, sanitation, and hygiene on the ground. And the major causes of such neonatal deaths and children's lives being lost or mothers' lives being lost are actually in the space of water sanitation and hygiene because of diseases such as sepsis. Right. So essentially, the idea is that by introducing technology innovations that target some of these key areas such as healthcare being an enterprise towards more intelligent systems using automation and digitalization, and finally towards personalized healthcare, even at the level where healthcare is currently not available, such as the rural areas where doctors' specialities are not available. So, how do we penetrate into such areas by using expertise that is available in the urban settings, and then basically using telemedicine and AI to deliver some of these interventions? So in our center of excellence, we essentially think of our technology solutions as being focused on conducting world-class research, also having capacity building by training students and also faculty in ongoing faculty development programs towards this emerging area of artificial intelligence and public health, and having industry grade solutions by interfacing with the industry and seeing wherever our solutions can be adopted to be scaled up on ground, and working very closely with implementation and policy partners from the central government and the state governments. So we have been doing this in respect to COVID for the last 1.5 years or so, and I will give some examples in that space. So what can these AI data platforms solve? They can solve the infrastructure gap. So think about water, sanitation, and hygiene problem as a problem of data. And I'll give some examples on how that can be used uh, to mitigate things like adverse pregnancy outcomes going forward. But having data platforms in place which help us record, report, and plan the public health interventions in a better way is one way in which digital technologies can help us, right? Then having new devices in place is another way. Education, analytics, and skilling is fulfilling the knowledge gap where we can skill the on-ground workers in the use of technology and basically bring more point-of-care intelligence and deliver interventions which can save more lives by providing more water, sanitation, and hygiene education to people. And again, I'll talk about that in our Washkaro project going forward. Finally, these interventions can be useful for making decisions to fill the policy gap, because a lot of decisions right now are made through expert opinions, but they can also be supplemented, if not replaced, by having predictive models and decision platforms. And so I'll talk about that also in a little bit on how AI and artificial intelligence and IoT can solve some of those challenges. So with that, basically, let's switch to the main theme with that overview on how we are tackling the AI/ML solutions for public health, right? So how do we use these for preparing for disaster and pandemics? And I'll basically lay this out as a story which started way back in 2013. And we were looking at these data sets which are unconventional. So we had data from about 2 lakh patients visiting OPDs of doctors on a single day in India. This data were collected by Chest Research Foundation, Pune, and essentially you can see that almost all of India was covered in this data set. And the question that we were asking was, this data set constituted of signs and symptoms that people were reporting to the doctors with. So what we wanted to ask was, can we now use AI to understand what are the main, not just the prevalences as we would do in typical statistical scenarios, but what can we learn about interventions that can be delivered on ground, and how we can learn about delivering them to mitigate some of the key conditions that we found in these data sets. in that analysis that was published in the Lancet Global Health in 2015, we were essentially looking at patterns such as the role of clean cooking fuel in airway diseases. Why? Because we found that the respiratory illnesses were the uh, major uh, cluster of signs and symptoms in patients visiting the doctors across India. But the interesting thing that we found here was we were able to combine these data sets from data sets on water, sanitation and hygiene, on data sets on LPG penetrance across the districts of India. How does the air pollution look like? And come out with models such as this. So this is a Bayesian graphical model, which actually allows us to ask that if I had to mitigate or prevent deaths due to, let's say, obstructive airway disease or adverse pregnancy or neonatal sepsis, what should I intervene upon? And that's exactly the kind of questions we started asking, and we were able to give proofs on basically how public health interventions could be learned from data itself by in these complex scenarios where each node here is is a health condition, and then what do we do at the intervention level or at the policy level to improve that health condition, right? And you will notice that these are not simple networks. These networks have a direction associated with them. So these are not correlations, these are actually causal networks. So they're a step beyond just correlations, because these tell us that if I were to act on this node, which is, for example, LPG consumption across India, it would causally influence obstructive airway disease, which is this child node, which tells us that if we actually improve the penetrance of LPG across the districts of India, how much it will influence the obstructive airway disease in those districts. So basically, having these kind of uh, causal networks guide public health interventions is what we started experimenting with way back in 2013. And that is what moved into our water sanitation hygiene analysis as well, as will come up in the next slides. But I'll just spend a couple of minutes here over why such kind of causal AI is important. The real world is actually asymmetric, right? Whereas correlations are completely symmetric, right? So the correlation between A and B is the same as the correlation between B and A. And there's a very commonly used dictum which says that correlation does not imply causation. And that's for a reason, because correlations are they are symmetric, whereas causality is asymmetric. So, so if you see a car, what is the probability of seeing a wheel in the same frame is not the same as if you saw a wheel, what is the probability of seeing a car in the same frame? The reason being that maybe all cars come with wheels, but wheels come with many other vehicles also. So this asymmetry is needed, which means that there is a directionality, that if we know about car, what is the probability of seeing a wheel is different from if we see the wheel, what is the probability of seeing a car, right? So this directionality is important in the real world. And this allows us to take interventions or causal interventions in public health, which are not possible with correlations, because those just may be confounding factors. So the challenge in AI is, how do we learn such causal directions directly from data? Right? It's easy to learn correlations from data, but how do we learn such causal directions, such as the one that I was showing in the previous diagram here? This is actually learned from data. We did not provide any information to the network about there being a possibility of connection between LPG consumption and obstructive airway disease, right? But the AI models learned on their own that districts where LPG consumption is high have lower airway disease, because maybe women are not burning chullas with wood for cooking, right? So how do we learn these from data is a challenge, and that's one of the frontiers area in in AI, which is called structured learning and causal modeling. So we use these kind of approach for modeling various scenarios. I'm giving an example of a similar asymmetry between the use of aspirin and heart disease in public health scenarios, right? Although the correlation will be similar, but there is a directionality in these relationships which can help us understand whether to give aspirin to a certain section of coronary artery disease people or not, right? And when we have these directions, what they allow us to do is to build to build intervention effects that can be mediation. For example, if we are looking at smoking, tar, and lung cancer, and we have such a directional structure, it allows us to actually say that if we eliminate tar from the lungs, okay, smoking and lung cancer become independent. I mean, then smoking does not cause lung cancer because it is actually the tar that is a mediating factor. So this allows us to actually focus on things that are immediate, proximate causes for the outcome, right? Also allow us to understand confounding factors and also competing factors, that if we can deliver two interventions, which one will give a better return on investment, right? So we started asking these questions, and this was basically an analysis that we did basically for adverse pregnancy outcomes in the state of Orissa, where a data set was available, and the data set had multiple factors, including mother's hemoglobin, uh, her cytokine profiles, her inflammation status, but also factors such as water availability in the toilets, soap availability in the toilets, and number of antenatal care visits, etc., that the mother got. Right. So using a very similar analysis that I showed in the previous slides, right, we were able to construct a network where we asked a question that if we have to mitigate adverse pregnancy outcomes in the state of Odisha, what should we be doing? What would give the maximum returns? Okay. And what I found was that, I'm sorry for the resolution, but this is the node which says adverse pregnancy outcome. Okay. And you can see that uh, it is connected with actionable factors such as this box here says number of antenatal care visits that the mother got. This says latrine use. This says water availability in the latrine. Okay. And this is a payoff node where we say that which one should we emphasize if we want to have the maximum payoff for mitigating adverse pregnancy outcomes. By the way, adverse pregnancy outcomes means deaths in children or mother due to infections such as sepsis, right? And this is no, I mean, this is known that more than 21% of communicable diseases in India are linked to unsafe water and lack of hygiene. This is an estimate from the World Bank. And more than 500 children under the age of 5 every day die every day from diarrhea in India alone, which means that it is extremely pertinent and important to learn that what should be our interventions to mitigate such adverse outcomes in the public health settings. And why am I showing this diagram? You can see that we had hundreds of variables. So each node here is a variable that we could have intervened upon, right? It could be, for example, improve the HB of the mother, hemoglobin of the mother. It could have been decrease the inflammation marker of some sort of the mother, right? But the model actually showed us independently, irrespective. I mean, we did not provide any information of any sorts of what is more important. It showed us that adverse pregnancy outcome is tightly coupled to water availability in the toilets, soap availability in the toilets, latrine use, and of course, the number of antenatal care visits that the mother had got. Okay, and basically this is a decision network setting that we constructed. So you can see that water availability is the highest ranking 11111 factor to maximize the payoff on the right hand column for decreasing the adverse pregnancy outcomes, right? Which means um, public health interventions can be learned from data by building such explainable and transparent AI models, which can help us prioritize where to act upon and what to act upon to be able to mitigate some of these adverse outcomes. Similarly, during the pandemic, actually, we were conducting a similar analysis, and the manuscript link is here. We were looking at different countries and their mortality rates, spread rates, and so on. So at least in the first phase of the pandemic, right? I mean, in the second phase, with the new strains coming in, everything was completely off, and we went into a totally different phase where there were many more deaths. But at least in the first phase of the pandemic, it was very clear that there was a link between countries' hygiene levels and the deaths that were happening. And water sanitation mortality, air pollution mortality, the SDG index, which is the Sustainable Development Goal Index for that country, the GDP of that country, and deaths per million population due to COVID. So this paper is online, but at least for the first phase of the pandemic, it was clear that, and when we analyze that countries which maybe which really had a higher GDP actually had a higher death rate to begin with, which is now a different scenario. But in the initial stages, there was something that was very clear, which was perhaps protective uh, um, for the Indian population, and we believe that there might have been a role of the water sanitation, hygiene, and the sanitary factors, and so on. So how do we de-entangle such factors from data itself? Was something that we were actually learning from these data early on. So there, these findings were supported by other papers also, which came subsequently. But as I said, the Delta strain and its emergence has changed the scenario. So it doesn't mean that countries which are poor and have worse water sanitation hygiene might fare better in terms of their death rates, which was not the case in the second wave of the pandemic. But it does give us an indication that at least in the first phase, the data-driven AI models do capture some of these influences in uh, uh, in at least in understanding the pandemic. So I'll talk about our Wash Karo project, which started at which actually was ongoing before the pandemic, which focused on delivering wash information to people. And the reason for this was that we were actually looking at sepsis readmissions, as I was saying, in the ICU settings. Um, and we found that a lot of readmissions were happening due to poor hygiene conditions at home. So one of the things that we thought that we need to deliver better information to people about water sanitation and hygiene. And how do we use AI for doing that? I'll talk about how we use AI for predicting what happens inside the ICU. But here we were asking, what can we do to outside the ICU settings, where basically um, this can be better communicated. So what we thought was that WHO keeps putting information online about water sanitation hygiene. Not even doctors read it, leave out the common man, common public, right? And many of us are actually, many of our population is not even educated enough to understand what, for example, the WHO says. But what we do understand are news articles and news media coverages, but there is a lot of misinformation in news media. So we thought, can we use AI to match what the WHO policy documents and the Ministry of Health and Family Welfare documents are saying about water, sanitation, hygiene, match these with news stories around the world uh, about water, sanitation, and hygiene, and use AI to match these and then to convert these into summarized, bite-sized pieces of information delivered as audios in Hindi. Right. So we started with Hindi because we thought that that's a language that people would connect most with. Um, so so this Wash Karo project started before COVID, and it was basically the idea was to deliver the right information to the right people in the right format at the right time. Right. But the Wash Karo project became very important with the onset of the COVID, because this wash uh, uh, intervention was much important in preventing the spread of COVID. And what were we using at the back end of these AI models were something similar to what this nature letter talks about. So nature letter talks about unsupervised word embeddings that capture latent knowledge. So we were making use of these language models that read text, because text is the most prevalent form of data available uh, around the globe and is underutilized. Right? Typically, we think about public health data as rows and columns. We think about public health data as as variables that may be arranged in columns and samples that may be arranged in rows. But we don't think about public health data in the form of free text, right? Or things that are available as text online. So we were inspired by these kind of techniques, which also, for example, Google uses to predict which word are you going to use next in your email or in your Google search bar. So we said, okay, let's use these unsupervised word embedding models to, to essentially compare news articles with WHO and MOHFW guidelines. We, of course, pre-process them. We summarize them using state-of-the-art neural networks and constructed word embedding models which capture latent knowledge, which I just talked about. Okay. And then we constructed a distance metric to understand how close are these two together. Is it information or is it misinformation? Right. And then basically these were vetted by five human experts uh, from the medical domain to basically come to a right metric for similarities and basically uh, capture these matched articles. Further, um, these were translated once we matched these articles. These were translated into Hindi, and using the Google text to speech engine, we converted these into audios. Right. So the whole process created a summary in audio format in Hindi. Okay, for people to get informed about WASH during the COVID time. Okay, and then basically we allowed user feedback whether that information was relevant to them or not. So if it was relevant, they could give a thumbs up or they could give a thumbs down. Right. So essentially, this was our WASH Karo engine, which uh, which basically talked about which basically was used in the Wash Karo project to provide the right information to the right people in the right format at the right time. And we showed that during the 4 months, 3 to 4 months that we were online with COVID information, uh, we were able to show that our models actually learned to provide more relevant information as people were giving feedback. So you can see that the green curve is the relevance count, which kept on increasing with time, and the irrelevance count kept on falling with time as more and more people gave feedback. So basically, which tells us that we can actually design better public health interventions on 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 important factors such as wash using artificial intelligence and make these more effective by training AI models. Unfortunately, Google Play Store changed its policies somewhere in August, July last year, July of 2020, where all apps that were providing COVID information were taken off and only government apps were authorized. So we were not allowed to carry forward with any COVID information, but we still now are looking, we are now a a Wash Karo TB app, which is having the same principles and the same methods to deliver information about tuberculosis mitigation and screening. Interestingly, we also found how do we segment these information. So we found that more females actually engaged with the app in Hindi than males, which tells us that in a very short period that we were able to work with COVID data, that which languages do we reach out to people with? What is your preferred mode? So we can design all these studies as digital interventions, which was previously not possible and now is possible to be carried out in a scaled up manner across the whole of globe actually, to design better interventions for public health, such as better messaging systems. So this paper is currently under review. We hope that it gets accepted, but it already has received a lot of attention. This was actually presented at the WHO, and we've been working with the government, especially the Delhi government, with whom we also developed a separate app for managing the pandemic, for better managing the pandemic. That is a Delhi Corona app. So that was more about the use of AI in public health settings, and the use of AI in designing messaging systems that can be improved using AI. But all of this actually came about from our project, as I was talking about earlier, from what we do in the ICU setting. So let me just spend a couple of minutes on that as well, because it's very important that we realize that a lot of things that happen in the ICU can actually be prevented outside the ICU. But what can we do once patients are admitted to the ICU is the Safe ICU project, right? So I already spoke about having water availability and soap availability in the home-based settings to avoid sepsis. But what can we do in the patients who are in the ICU settings? Although it is not related directly to WASH, but it is very much related to AI and the models that we kind of use in our healthcare settings. So in the ICU settings, we have a project called the SAFE ICU project, which is Sepsis Advanced Forecasting Engine. Because ICUs are data-rich environments, these generate about a gigabyte of data per day. These are routinely collected and routinely lost. So what we did was to basically warehouse these data, which just shows the value of data in health settings, be it public health or hospital settings, because once we were able to warehouse these data, which are about a gigabyte of data per day, and now we have more than 1.5 million patient hours of continuously monitored data over the last 6 years. So basically, then we can start using these data to make decisions in the ICU. And we believe that these kind of data automation methods and predictive modeling approaches are also very relevant to public health challenges, such as the ongoing pandemic, where dashboards are important, visualizations are important. So we started out really lean. For example, how do we tackle the challenge of antibiotic usage in the ICU? Because antibiotic resistance is a major challenge in the ICU. How do we tackle with data quality issues in the ICU? Once we had these data streams flowing, we could ask questions like, is the baby or the child in the right oxygen saturation range in the ICU settings? And then basically start to develop models that are more predictive. Okay, beyond these descriptive settings, how can we start predicting which children or which baby, which child is going to crash in the next 6 hours, 12 hours, and 24 hours, so on. This can be very much applied in the public health settings, and I have an example going forward. If you just take this out and apply in the longitudinal setting in the public health, right? So think about these time series as, so these are heart rate, oxygen saturation, pulse rate, respiratory rate that the patient is being measured for continuously in the ICU settings, right? So every second, there's a sensor that is sending out data, and we warehouse that, right? But now, for example, we have some of these data collected uh, for public health as well, especially for COVID on a daily basis almost. So where we have these time series, and we know some event happens at this red line, can we start looking at these data and start predicting the likelihood of event much before it happens? That's the kind of questions that basically we ask using these temporal data sets, be it ICU settings or be it public health settings, right? And in the ICU settings, we make use of imaging techniques such as these thermal images. We use computer vision models to understand how these models can learn to see relevant features in the babies that can predict critical outcomes such as shock in the ICU. I won't go into the details because it is off topic. It is not water sanitation hygiene. But the key idea here being that we can use a combination of data sets, including images, text, signals, to really start predicting onset of conditions like shock in the ICU 0, 3, 6, and 12 hours, right? And in the public health settings, for example, the spread of COVID. Even in the pandemic settings, I think if we want to prioritize which patients would need ventilators due to COVID in the next 24 hours, is a question that we could ask using very similar approaches of building longitudinal models. So I'll skip all of this where we showed how these models actually work with quite high accuracy in capturing shock and predicting shock up to 12 hours ahead of time. But the key thing is that now we are basically taking these models on ground. And shock is a very common outcome of sepsis and infections. Could be dengue, could be diarrhea, could be hygiene related infections, right? So we got a little bit derailed because of COVID, so we haven't been able to actually take these. But the plan was about a year back was to take these models on ground in the health of ASHA workers because these are non-invasive, non-contact methods. You just click a picture and the picture gets uploaded to a server, and basically predictions can come about the likelihood of shock in a given child or an adult. So think about this as a peripheral screening test that you could do for COVID, which also leads to shock, by the way, uh, in peripheral health settings, right? In which people need urgent attention and so on. So that's where basically AI kicks in for public health settings. Finally, in the next 5 minutes or so, I'll talk about two themes which are related. One is how is AI used for helping better preparedness in pandemic? Okay, here we're using genomic signals to see how the similar kind of models that I talked about previously about learning to read text, since genomes also have letters, right? And genomes come with words such as 3-base codons, which which code for proteins. We can actually train models to read the language of the genome and to understand the grammar of how COVID genome is changing across time. So to cut a long story short, you can read our paper here. It is currently under review. And we are planning to come out with this dashboard, which on a daily basis reviews what is happening around the globe with strains. But what we currently show is our models actually captured uh, the, uh, the temporal and the spatial emergence of strains ahead of time in 16 countries. Why do I say ahead of time? I'll show in the next slide. But you can see that England and Scotland showed very similar grammar patterns. England and Brazil showed different patterns. And you can see on this, this is 2021 and this is 2020. So across 2020 to 2021, there was a clear pattern of how the grammar of the COVID genome changed. And we use that change to really cluster different countries and to see if we actually can capture emergence of new strains. And here is how we see that. So on the top right is the curve, which the blue line says new cases in Brazil, right? And the red line is a dimension 3 of the underlying grammar, and blips in that dimension, the number of changes in that grammar dimension. Okay, and you can see that one of these dimensions, which is dimension 3, we have 36 dimensions, but in the third dimension we see a very clear lead time of about 1 to 2 months ahead of the cases that start rising. So which means that if we track this dimension, we should be able to actually look at how cases may change over the next couple of months. And when we went back and look at the biology of these, we do find that these dimensions, such as dimension 3 and 12, actually have the language patterns that variants of concerns and variants of importance, such as delta strain and now delta plus strain, are actually harboring these changes in TAA, GGG, and AGC, etc. So our models were capturing the biological relevance as well. So that is how basically we can be more prepared for pandemic. Now imagine the model that I showed earlier, messaging, and combined with prediction models, we can design effective pandemic uh, prevention strategies and have preparedness systems put in place. And that's exactly what our lab is currently working on in partnership with governments and a couple of on-ground agencies, NGOs that work on the ground. Finally, I think one of these videos that I wanted to play was how AI helps us learn uh, interventions in where there are no data, right? So think about AI, for example, learning to play this Mario game. All that we tell this model, which is called a reinforcement learning model, is that the Mario player has to survive. It has to gather maximum score, finish the game in minimum time, and that's it. And have some things put out in the environment. And basically AI over time starts to learn, as you can see on the top right and the bottom right. It starts to learn what actions should the Mario player take to maximize the reward and play in the best possible manner. So we thought if basically, and people have been doing this for biological scenarios such as drug design, how to design better drugs by learning how to fold proteins in a better way. Right? So folding proteins is a challenge, which is a very tough challenge. It is one of the grand challenges in biology. So recently, the Google AlphaFold algorithm solved this problem by achieving state of the art in achieving protein folding, which led to these two science and nature stories about AI triumphing at solving protein structures, right? In this challenge, where you can see that in the challenge, in the global challenge, using similar techniques that I used to play Mario games, that the computer I used to train computers to play Mario games, were used to train computers to fold proteins, and they perform with this much margin, a log order of magnitude higher margin. But we asked a different question. We asked, can this be used for learning resource allocation in pandemic scenarios? Right. And this could be in, for example, learning to provide better oxygen, distribute the oxygen in a better fashion, or maybe vaccines in a better fashion. So here we were dealing with vaccination strategies way back in 2020 when it was announced that vaccines have entered phase 2. So this paper was posted in September of 2020 when we did not even have a vaccine. And we put out this paper where we said that can we learn an AI-based strategy to guide better vaccine allocation across the states of India using very similar approaches which are used to play Mario games and to fold proteins. Okay, so think about these things as the environment in which that player is playing. Okay, the environment is how many ventilators in that state, how many ICU beds in that state, what is the susceptible population of that state, what phase of pandemic are we in that state, what is the age distribution, how many healthcare workers, what is the recovery rate of that state, right? So think about that as environment, and then the reward is that we want to uh, basically achieve the end of the pandemic in the least possible time, right? And that's where we started running our models and see actually our models started to learn. And that was fascinating to us that that we could learn to prevent active cases by using such reinforcement learning and contextual mandate models. Not to say that, I mean, these models are not used in the real world policy making because perhaps there's so many other challenges that policymakers have to face. But we have a platform that actually does guide how can vaccination strategies be improved, at least in form of distributing vaccines across the states. And we show that we will always have a positive number of cases prevented if we follow such an intelligent strategy for distributing vaccines. And you can think about this as any resource allocation problem. Okay, you can go and read a paper, and basically what we're doing now is we're repurposing this to generic resource allocation problems in public health, not just for vaccine, because we realize it could be used for oxygen, it could be used for any disaster preparedness where resource have to be allocated optimally, right? So we have a dashboard that actually shows these models in working in place. So I think that's where these models can work, for example, to deliver. If we have to even to spread information, and even spreading information is not without cost, right? So these models, or to spread, let's say, or to provide an intervention which could involve uh, providing, let's say, soap to people, right? So, and all of that, or providing clean water. How do we allocate resources is what we can achieve with these kind of models using AI. So I think I'll stop there. I have come to the end of our 45 minutes. We are basically with summary of the talk that public health and environment are tightly interconnected. And now we can increasingly put more data systems in place which can synthesize information from unconventional and conventional data sources and to guide health and environment interaction. I showed that about airway diseases and LPG consumption. I showed that about water availability in the toilet and adverse pregnancy outcomes. I showed that about sepsis and how it can be prevented in the ICU settings, and how information can be disseminated using language models and so on. Second message is that AI comes in many flavors. So I talked about flavors, for example, that use text data, flavors that use images, right? AI that uses simulation, such as the reinforcement learning that I showed in the end. However, causal AI model can help us learn interventions. The ones that I showed earlier, where we have a cause-effect directionality, where public health interventions can be designed and then can be delivered as, let's say, messaging systems and so on, right? And for that, language models can help us deliver better messaging interventions. And then simulations can help us design better policies. And that's what I showed in the end, that simulations can actually help us design better better resource allocation strategies and to design better policies. Right. So with that, I summarize my talk and come towards the end of this talk. And I would like to acknowledge my lab, my team, and my collaborators, and also my funders who have been supporting our research over these years, and some of which I talked about today. So thank you very much.